Okay. Good morning. We'll present the case of one very important case called hypokalemia. That too, there is severe hypokalemia. And what is meant by hypokalemia? There is something called like any serum potassium less than 3.5. Like normal potassium will be 3.5 to 5.5. Anything less than this will cause it. We will call as hypokalemia. So there is usually less than 3 to less than 3.5, like more than 3, anything more than 3 to 3.5 is a like it is also called as hypokalemia, but is not, if the patient is not any symptomatic, it can be maintained rate, like it can be treated normally because there is no any symptom. So his age is 32 years, no? He is a 34-year male patient. He presented to our hospital with complaining of there is something called muscle tiredness. Like he was having numbness in the muscles. He was having numbness in the both hands, and after that, suddenly after 1 hour, he got quadriplegia. There is like paralysis all the four limbs. Like there is no energy, like there is no any limb weakness. There is no any upper limb and lower limb. Both limb weakness was there. That is called as quadriplegia. He is a 34-year male patient who presented to our hospital with complaining of sudden onset of quadriplegia and the severe weakness of generalized body weakness and mild abdominal discomfort. Okay, with this complaint he admitted to our hospital. On initial assessment, we seen that as the patient is having quadriplegia anything, so we have to examination wise is first, like paralysis part has to be ruled, because if the patient is having paralysis, it may be a single, like if the right hemiplegia, left side hemiplegia, maybe a single side lobe will be involved. In this patient, he is having quadriplegia, and by an examination, he is like his BP is normal. His BP is 130/80, and his pulse is 98, and everything was good, and saturation, everything is okay. And what you have to do will clinically, we have examination from I have examined for his pupils. He's just give that torch. I will examine the pupil now. Kantagiri, aram se. You can see the both pupils are normal and reacted to lights. Okay, normal and reactive. The pupil examination is okay. If the patient is having bilateral, like if the patient is having only pinpointed pupils with this quadriplegia, it maybe goes towards something like any stroke, anything. If the patient is having unequal pupils with one-sided weakness, it maybe goes towards the head injury or stroke. Now he is having normal pupil examination, so normal pupils and with quadriplegia. Something we'll do for the next examination. Patient is conscious and well oriented, so plays for some time anything. Nim hesare andre? Okay, he is normal, talking, everything is normal. The only one important thing I am examining is, as he is having muscle weakness. So what you have to think is there is something called hypokalemia. So hypokalemia, if the patient is severe hypokalemia, it should be like first there is something muscle weakness, there is muscle tiredness, and the muscle weakness is also presentation of the hypokalemia. And there are two entities of hypokalemia. One is neuromuscular entity, one more is a cardiac entity. If the patient is this patient is having neuromuscular complications of the severe hypokalemia, in some patients they will present with severe cardiac arrhythmia, palpitations, and that is also because of the severe hypokalemia. As we took the ECG, now this ECG is like only there is a hypokalemic is like inverted T wave with formation of U waves. There is a formation of U wave in the peripheral V5, V6 and V3 everything, and only hypokalemic changes were there here, and there is no any arrhythmia, every regular heart rate, everything was there. So only one thing is, this patient is not having any cardiac symptoms. This patient is having muscle weakness, in neuromuscular problems he is having. So what you have to do is, how to proceed with the patient is, you have to do for the serum electrolytes report. As we took the serum electrolytes, his electrolytes is only, first the potassium will be, his potassium is, sodium is normal, everything is normal, only potassium is 1.21. You just imagine the normal potassium will be 3.5 to 5.5. Now this patient is having only 1.2. So this is a severe hypokalemia that leads to a muscle weakness, everything. So how to proceed with the hypokalemia? We know that patient has had a hypokalemia and muscle weakness, everything. So we have to do what the causes of the hypokalemia. We have to ask the history of loose motion, history of vomiting, history of any fever, anything. Why loose motion and vomiting? Because the patient is having more than 20 times loose motion, they will have trained to lose the potassium through the motions. There is a volume loss through the GIT. So this volume loss through GIT, also loss of the potassium may be there. So because of this maybe GIT loss may be there. So vomiting because of the one is volume loss, one more is metabolic acidosis patient, they will vomit a lot because of the severe vomiting, potassium loss may be there, and fever history anything to be ruled out. And if the patient, as this patient is not having any fever history, not having loose motion, not having vomiting, not at all having anything, so what you have to do is we have to rule out the causes again. Usually we found that patient is having hypokalemia. How to proceed the patient with the hypokalemia? Hypokalemia maybe if the patient is not, we are not clinically, we are not finding any history, like patient is not having loose motion, not having fever, anything. What you have to do, we have to rule out the causes of the potassium. There is only one route of causes of the potassium, maybe urinary loss. Is it a urinary loss or is it a GI loss? GIT loss means there may be vomiting, or any patient is having long standing RT like nasogastric aspiration, because of the continuously aspiration, potassium may be low. This patient is not having any not having any rise to anything, and because of some operations after the post operative, like any GIT operations, like any gastrojejunostomy operation, this patient is not at all having any operation history. So there is no cause of GIT loss. There is only one cause, maybe urine examination. If you are not finding any other, like even after correction of the potassium, we are not found any other like causes of the hypokalemia. What you have to do is we have to send the urine potassium. So we have to send the urine electrolytes. After urine electrolytes, we have to see whether in the urine electrolyte, if the potassium, there is very important thing is if the potassium is more than 20 millimole per meter, millimole per liter, like more than 20 to 30 millimole per liter, it is called as renal loss. If the potassium in the urine is less than 20 millimole per liter, it is not because of the renal loss, it is a GIT loss. We did the urine potassium. If the potassium is come like less than 20 millimole per liter, so what you have to do, you have to think it may be having loose motion, it may be having metabolic acidosis, it may be having because of any other nasogastric aspiration continuously, it may be because of the any operations like abdominal causes. We have to rule out these things. In the same way, if the potassium is more than 20 to 30 millimoles per liter, what you have to do, definitely it is because of the renal loss only. In again renal loss, there are two types. One is potassium, like renal loss with hypertension, renal loss without a hypertension. With renal loss with hypertension or without hypertension. Without hypertension means normal tension, normal BP or hypertension. First we'll see that if the potassium is urine potassium is more than 30 millimoles, it is a renal cause of the renal loss of the potassium. With hypotension or a normotension DPO, what you have to see is because of maybe we have to retrogradely we have to ask the question like, is he on any anti-diuretics treatment, like for BP he is taking any thiazide diuretics, is it an alcoholic patient continuously he is in need of thiazide diuretics, is it a cardiac failure patients leads towards any diuretic using long-term diuretics, anything you have to be low. And one more thing is there is a loop diuretics, maybe furosemide, anything, the Lasix, anything chronic history is it taking, you have to rule out everything. This is with normal BP. With hypertension, there are usually congenital normal hypertension means there is something called Conn's syndrome, everything that is a different entity we will discuss later. The only thing is we have to rule it. First you have to depend upon the hypokalemia. We have to see if the hypokalemia is not treated, we have to send the urine for electrolytes. Urine electrolytes shows the potassium, hypopotassium. Like if the urine potassium is more than 30 millimoles per liter, it is a renal loss. Less than 20 millimoles per liter, it is a gastrointestinal loss. Gastrointestinal loss should be supplemented immediately. And if it is having a really renal loss, we have to see for whether it is alkalosis, metabolic alkalosis, anything is there. Is he on any other like chronic diuretic therapy? That you have to stop everything. This is the only thing. I will go now examinations. Okay. Patient is having muscle weakness. Muscle weakness means there is something called, if patient is also having a obstructive bowel loops, like his bowel should be because of the less potassium, his bowel obstruction may be there. So functional obstruction of the bowels, that is paralytic ileus may be present with paralytic ileus. So what you have to take here, any patient with a severe hypokalemia, we have to first see for the examination, we'll read later. We have to see for the abdomen. We have to see for abdomen whether he is having any distension. There is no distension. Only one important thing is we have to auscultate for the bowel sounds. If the bowel sounds are present, then we can give orally. If the bowel sounds are absent, we can't give orally because of the severe hypokalemia, bowel loops were absent. Like bowel sounds were, there is a mobility of the bowel is absent, so that anything will give, it will not move properly. It will become obstructive paralytic ileus type of symptoms. Now I am examining for vowel sounds. Yes, this patient is having some gurgling sounds and clickers in the like vowel sounds are present. So it just means that only loss of muscle power is there. So we can give fluids. That too only fluids you can give less than 100 ml per hour. We have to give in this examination. And I am doing any examination, any hardness or tenderness, distension, anything is not there. Abdomen is fully soft. There is no any organomegaly. There is no any tympanic node. Resonant node, there is no any resonant tympanic node to see the obstruction symptom. There is everything is abdomen is normal. We'll examine it for the limb now. What you have to, there is a tone you have to examine. This see again, this tone is very like it is a hypotonic patient. Severe hypokalemia will cause hypotonia. Okay, we'll see for the muscle like deep tendon reflexes. This knee jerk is see absent deep tendon absent result. Deep tendon reflex is absent now. This ankle jerk also absent. Here knee jerk absent. Okay. Only hypotonia. ಸ್ವಲ್ಪ ಕೈ ಹತ್ತಿರ ನೋಡು ಸ್ವಲ್ಪ ಎತ್ತಕತ್ತೈತಿ ಒಟ್ಟಾಗೋತು ಸ್ವಲ್ಪ ಹಿಡಿದ್ರು ಗ್ರಾವಿಟಿ ವಿತ್ ಗ್ರಾವಿಟಿ
ಹಿಡಿದ್ರೆ
ಎತ್ತರಿ ನೋಡು
ನನ್ನ ಕೈಲಿ ನನ್ನ ಭಾಷಣ
ಇಲ್ಲ ನಾ ಹಿಂಗೆ ಹಿಡಿದ್ರು ಇಲ್ಲ see the presentation is very important. He is unable to even move if the patient is having sensation ಅಂದ್ರೆ ಮುಟ್ರೆ ಎಲ್ಲ ಗೊತ್ತಾಗಲ್ಲ
ಮುಟ್ರೆ ಗೊತ್ತಾಗ್ತದೆ
he is having full sensation but only a muscle power is not there. You can see this. The same for limb also. Very severe hypotonia. So only thing examination, since grossly I am telling, the examination for per abdomen to rule out the any kicks and gulls to rule out the paralytic ileus. One more thing, hypotonia or hypotonia to rule out the muscle weakness, and the power is totally a zero. There is no power. With gravity also patient is not moving, and his deep tendon reflex were absent. And his potassium, we are what how to supplement the potassium. There is how to manage this patient, because if the patient is not having like we are managing one more investigation. What are the investigation we have to send is serum potassium, like serum electrolytes, urinary electrolytes, and the serum magnesium has to be because of the some magnesium there may be channel changes. That's why severe hypokalemia may be there. So what you have to do is we have to supplement the potassium. How to supplement the potassium? Like if the patient is not having arrhythmia or any other else like cardiac disorders, actually some cardiac disorders patient will have severe ventricular ectopics, patient will have some lots of arrhythmias. These are also the complications of hypokalemia. If the patient is not having ventricular ectopics, not having any arrhythmias, so we only have to manage. Actually once if the like how potassium correction is given by, we have to give the potassium injection 40 milliequivalents per liter, like per liter have to be given. So we have given from 500 ml NS with 2 ampoule of kesaf. So this 1 ampoule kesaf contain 20 milliequivalent and 2 ampoule contain 40 milliequivalents. This have to be changed after you have to give now, and you have to repeat after 6 hours. Again you have to give one more 12. Totally 40 to 80 milliequivalents per have to be corrected, and it should not be like more than 20 milliequivalent per hour should not be corrected. Anything higher than more than 20 milliequivalent per hour, it is a danger. So only thing is you have to do when patient will be a normal, and after 3 to 4 hours, if the patient age is more than 60 or more than 50, they will have some ventricular ectopics definitely, and they will have life threatening problems. They will like their muscle power will come after 5 to 6 days. If this patient is having young age and we are correcting potassium now, and this is the second day of like yesterday night he came. Yesterday 40 milliequivalent we were given. Again we have repeated. Yesterday's potassium was 1.2 and today's potassium is 1.98. So suddenly it will not come. So we have to give same corrections 2 to 3 days. And if the patient is having bowel sounds, we have to give. See, patient is asking, he want to move his hand, but is unable to move. He is asking my help. Okay. And we have to give potassium with magnesium. If the patient is having bowel sounds, we have to give like orally also less than 100 ml per hour, and we can give magnesium, ultra magnesium tablet have to be given for 200 ml. And this is a presentation. Thank you.